Okay, welcome to the second day or the third day, I don't know, of this 6 months international hemodialysis course. We start this session by our chief Dr. Tarek EL Tantawy. Dr. Tarek is a consultant and is interested in education and continuous medical education, workshops, and there's a lot of activity either in our government or in our society. So Dr. Tarek today will speak about the management of TB in secondary patients. Please, Dr. Tarek.
Many thanks, dear Chairperson Professor Adam Bakr, for your kind introduction, and I welcome all our visitors to Egypt from Africa. And today I will target a topic which is rare in my practice, but actually serious, how to deal with TB, tuberculosis patient, and CKD. Outside today, I would like to talk about introduction, why increase the incidence of tuberculosis in CKD patients, clinical presentation of tuberculosis in CKD patients, what about diagnosis, and of course, how to start treatment. I should have an orientation about tuberculosis treatment, first line drugs, second line drugs, because all you know about bacterial resistance, and I would like to finish with my conclusion. Patients with renal disease are at increased risk of tuberculosis. This is true for patients with CKD. It has been estimated that patients undergoing dialysis have 10 to 12 fold higher risk of developing tuberculosis compared to general population. As regards the incidence of tuberculosis in transplant patients, in North Europe from 1 to 4%, and in North America from 0.5 to 1%. Why increase the incidence of tuberculosis in CKD patients? In the case of pneumonia, there is granulocyte function like chemotaxis and the adherent phagocytosis are detected. There is decreased interleukin 2 production by T helper cells, and effect on co-stimulatory function of the antigen-presenting cells. The resistant inflammatory state of monocytes, which is caused by uremia per se as well as by dialysis treatment. As regards population of CKD on dialysis procedure with the conventional cellulose membrane causing activation of the alternate complement pathway with increased introduction of interleukin CD11B, CD11A, and L17. All these correlate with leukopenia. Impairment of phagocytosis was often encountered with capocam membrane. I think it's now obsolete from dialysis population. As regards transplantations, immunosuppressive drugs with potent calcineurin inhibitors, tacrolimus, Prograf, and potent antiviral drugs like mifeprintofetal also causing impairment of cell-mediated and humoral immunity of the patient. Also, another non-immunological issues regarding to diminish the immunity of our patient, CKD, like malnutrition, vitamin D deficiency, and of course hyperparathyroidism. Clinical pictures. Actual patient presented with sequence onset of symptoms, fever, anorexia, loss of weight, and of course all of you are known that anorexia and loss of weight may mimic uremic symptoms. There is a study from being attacked. They found fever accounted for about 72% of cases, malaise in about 69%, and weight loss in about 54%. However, the cough and the hemoptysis, the classic symptom of tuberculosis, in the general population are less frequently reported in dialysis patients, with mean 22% of cases. Our patients in hemodialysis, clinical presentations, they may present with a lot of interstitial symptoms, but actually males are affected twice more common than females. Interstitial symptoms like headache, chills, and shortness of breath, about 30%, and also actual symptoms that divert us for the diagnosis of tuberculosis in our cases, dyspareunia of unknown origin. Also, pleural effusion encountered in about 50% of cases. As regards the organs affected, lung is the most common in our dialysis population, followed by the abdomen, urinary tract, meninges, and bone and joints. Also, there is disseminated miliary tuberculosis, range about 10 to 15%. Also, tuberculosis pneumonitis was encountered in patients with LCD under continuous ambulatory peritoneal dialysis. As regards kidney transplant cases, the presentation, as usual, males are more affected than women. Interstitial symptoms are counted. A lot of cases, lung is the most common site in transplant cases, followed by the abdomen, pericardium, thalamus, bone, and joint. Miliary may be also encountered in 7 to 36%. Pyrexia of unknown origin is another issue we have to concentrate on it. Also, neurological tuberculosis is more common after transplantation, which is a serious complication and actually need long time of treatment up to 1 year. Shift to other issue, which is important about how to diagnose. Diagnosis actually depends on the finding of positive acid fast lysed meat, positive culture of microbacteria tuberculosis, typical histopathological findings. Effect should be made to obtain appropriate materials for culture, which should include sensitivity testing. However, the diagnosis of tuberculosis is hampered by the common occurrence of negative modified protein derivatives and of skin test, which is found in about 40 to 100% of cases. Paradoxically, and despite the high rate of energy to intravenous administered antigen in uremic patient, high rates of positive Mantoux test, about 6 to 19%, have been found in routine screening of dialysis population without any history of active tuberculosis. Thus, due to frequent extrapulmonary presentation and non-specific symptomatology, a high index of suspicion is required, coupled with a need of invasive procedures, including liver, bone, lymph node, and peritoneal biopsies. So, recommendation: all patients with chronic kidney disease considered at risk for tuberculosis should have a history of prior TB or TB contacts, any history of prior tuberculosis treatment check, including drug taking and treatment durations, and appropriate clinical examination and chest X-ray. Any patient with CKD with abnormal chest X-ray consistent with past tuberculosis or previous history of extrapulmonary tuberculosis, but who has previously received adequate treatment should be monitored regularly and considered for referral to and assessment by specialists with an interest in tuberculosis, either thoracic or infection disease physician. And the decision of chemoprophylaxis regimen should be made by a team consists of thoracic or infectious disease physician after discussion with both patient and renal team. So our patient, CKD with tuberculosis, when he is in need of management, do not refer him or them to thoracic physician only. You should adjust the doses. This is an issue of very important end. The diagnosis of latent tuberculosis infection is based on information gathered from medical history, very important, physical examination, chest radiograph. In certain circumstances, sputal examination and immune sensitivity test or interferon gamma release. Timing of screening. For patients with CKD, there is no evidence on when or how to screen for latent TB infection. Screening all patients with advanced CKD or even only those on hemodialysis or peritoneal dialysis would be time-consuming, expensive, and unlikely to be cost-effective. The current practice in most renal units is to give prophylaxis to all at risk without assessment. Chemoprophylaxis could be offered to those with latent tuberculosis infection before transplantation, including the need for post-transplant prophylaxis. Interferon gamma release assays are whole blood tests that can aid in diagnosis of mycobacterial tuberculosis infection. They do not help differentiation latent tuberculosis infection from tuberculosis disease. And in the United States, FDA approved two tests. In our country, we have here interferon TB gold tube test and T-spot TB test. It's the gold standard for diagnosis with high specificity and sensitivity. All patients with CKD on hemodialysis or CABD and prior to renal transplantation should have chest X-ray and any abnormalities investigated. Most patients will have normal chest X-ray and response to tuberculin or TB specific antigen will be needed for screening for latent tuberculosis infection. The TSCT test is unreliable in patients with advanced CKD and those on immunosuppressive agent. A positive test may be useful, a negative result cannot be assumed to be at all negative. So we have to think about the need within the agenda confronted in our practice. Chemoprophylaxis, there are three potential chemoprophylaxis regimens. Isoniazide for 6 months, rifampicin plus isoniazide for 3 months, or rifampicin for 4 to 6 months. Rifampicin and pyrazinamide for 2 months was started the new study, but have a lot of complications, including hepatitis and some fatalities are reported. Choice of regimen for antituberculous drugs, we have a lot of everything to choose and to tailor according to the patient, according to the situation. You have to individualize antituberculous drugs for every patient. So 6 months isoniazide, our lower hepatitis profile. 3 months rifampicin and isoniazide have better compliance with the patient, with shorter duration and better adherence and less risk of drug resistance to have combined 2 antituberculous drugs. 4 to 6 rifampicin also preferable than long-standing duration of isoniazide. No chemoprophylaxis regimen is only effective, protective efficacies of 60 to 65% have been reported for isoniazide for 6 months, and 50% for combination of 3 months for rifampicin and isoniazide. There is strong evidence that regimen longer than 6 months, the isoniazides have only very minimal additional advantages at the cost of an increase in the risk of hepatitis. I will shift to another important issue about the pharmacological properties of antituberculous drugs determine how their levels are likely to be influenced by decreased elimination in renal failure. Of course, a lot of drugs will be eliminated through the kidneys, which is affected by impairment of GFR. Clearance during dialysis population, some drugs will be cleared by dialyzers. And another important issue about interaction with chemotherapy drugs, and we'll see the following slides how much expose the patient to serious side effects. So treatment duration should, however, follow a guidelines, 6 months for most cases of fully sensitive disease, with exception of TB involving the CNS, when treatment should be for 1 year. As regards the isoniazide, it's metabolized by the liver, not dialyzable. Low doses from isoniazide is not effective, so we give the patient a full dose. And as you see in your slides, stage 1 to 3 CKD isoniazide would be full dose about 300 milligram. Stage 4 to 5, we use also the same dose. And in renal transplantation, we can give 15 milligram per kg up to 900 milligrams thrice. We should be aware of side effects of isoniazide, neurotoxicity, gastrointestinal toxicity, and in some cases renal failure. As regards vitamin C, also metabolism by the liver and urinary excretion account for only 10%. Some reported cases of acute kidney injury following treatment. There is widespread arrangement that the dose of rifamycin need not be altered in renal impairment, and that drug level not be monitored. And the daily dose about 450 up to 60 milligram per day. Pyrazinamide also is metabolized by the liver, unfortunately it stays in the blood for up to 48 hours. Owing to its effect on uric acid retention, it may lead to hyperuricemia in the gout. It is significantly eliminated in hemodialysis patients. No data about peritoneal dialysis, and due to the possible delayed elimination of the drug and its metabolite, the dosage interval should be altered in stages 4 and 5 and inpatient dialysis, and the dose about 20 to 35 milligram per kg per dose 3 times per week. As regards ethambutol, about 80% of ethambutol is excreted unchanged by the kidneys. In patients with renal failure, excretion of ethambutol was significantly reduced following the usual dose of 15 milligram per kg. Ocular toxicity is largely dose dependent. Ethambutol has been detected on dialysis. It has improved efficacy when administered in high doses less often than in a daily lower dose. Serum monitoring should be done, and trough limit should be less than 1 milligram per ml at 24-hour dose without dialysis. Recommendation doses 15 to 25 milligram per dose 3 times per week. Aminoglycosides, you have to know streptomycin, terramycin, abacatine, and capromycin. Streptomycin causes less vestibular toxicity, less nephrotoxicity. Approximately 40% of streptomycin, terramycin, abacatine, and capromycin are removed by hemodialysis when these drugs are given just before hemodialysis. And the American Thoracic Society (ATC) recommend 20 to 15% milligram per kg doses 2 or 3 times weekly, and drug level should be monitored. This table showed the different chemoprophylaxis available as a first line of treatment, and this is the usual doses and with modification according to stage of CKD and renal transplantation. Second line, I will go slowly because of short of time. Fluoroquinolone, cycloserine, paramine salicylic acid, nicotinamide, linezolid, and the linezolid in use for more than 28 days, we have a lot of complications. For patients on dialysis, special situation, stage 4 and 5 CKD dosing interval should be increased to 3 times weekly for ethambutol and nicotinamide and aminoglycosides. Isoniazide, rifampicin can be used in normal dose near impairment. Pyridoxine supplementation should be given to isoniazide to protect against peripheral neuropathy. Ethambutol and aminoglycoside have the disadvantage of renal clearance, the need for increased dose interval, reduced dosage, and drug monitoring. I think it's an issue. As regard, I would like to shift to an important issue on practice. Rifampicin in particular can interact with immunosuppressive regimen, increasing the chance for graft rejection, and the doses of mycophenolate mofetil, tacrolimus, and cyclosporin will need adjustment. Corticosteroid dose should be doubled in patients receiving rifampicin. Rifampicin is a drug most likely to interact with immunosuppressive treatment by induction of a number of liver enzymes, including uridine diphosphate, glucuronidase transferases, monoaminostasis, glutathione sulfate, transferase, and cytochrome B450. Once the rifampicin has been stopped, liver enzyme induction usually takes 2 weeks to return to normal. As a severe program, sometimes cause hepatotoxicity, which has to be differentiated from hepatotoxicity due to anti-tuberculosis drugs. This table showed what's available as regard first-line drugs and second-line drugs with modification according to CKD stages of transplantation. In my conclusion, active tuberculosis should be excluded in patients with CKD by appropriate investigation in patients who have an abnormal chest X-ray or history of prior pulmonary or extrapulmonary tuberculosis that has been either inadequately or not previously treated. Chemoprophylaxis should be given. For patients with stages 4, 5, and 5 CKD, dosing interval should be increased to 3 times weekly for ethambutol, pyrazinamide, and aminoglycosides. Treatment can be given immediately after hemodialysis to avoid premature drug removal. Close cooperations between renal physicians and the specialists in the management of TB is strongly recommended. Rifampicin in particular can interact with immunosuppressive regimen, increasing the chance for graft rejection, and doses of mycophenolate mofetil, tacrolimus, and cyclosporin will need adjustment. Corticosteroid dose should be doubled in patients receiving rifampicin. At the end, thank you.
Thank you, Dr. Tarek, for this comprehensive review of the CKD and the TB. And you nicely presented some data about renal transplantation. If you can kindly allow me to discuss with you step backward. Patients with CKD having TB, are they candidates for renal transplantation or not?
You raise an important issue. We have to manage and treat the patient fully before transplantation. As you know, Professor Adel, about the dilemma of infection and the drug interaction with antibiotic drugs, with immunosuppressive drugs. So we have to be wise enough. We give him a full time even after complete cure with proper antibiotic drugs before the choice of renal transplantation.
Is a pulmonary TB or urinary TB?
As you see, our target TB is pulmonary or extrapulmonary, and we have, fortunately, in the last decade, maybe not available before, the era of interferon gamma release assay. So we have to be should be negative, and I think, and also from the guidelines to give the patient about 1 year post-complete cure from tuberculosis to start the issue of renal transplant workup.
Excellent. Also, they recommend eradication of infection by having bilateral nephrectomy details heredity. And also they recommend post-transplant chemoprophylaxis with INH for at least, they said 6 months, 1 year, 1.5 year. Questions from the floor?
Okay, thank you.
Thank you, Dr. Tarek, and now my dear friend, Dr.